Hello, John Delay.
Hi, Prof.
Yes, hi.
Hi.
I will let
Can
you share the screen. I will stop my screen share and I'll let you share
Okay.
the screen.
All right, Prof.
Okay, so I've stopped mine and
Okay.
now you can try and share. Okay.
All right.
Okay, good. That's fine. Hi, Yashoda.
Hi, Prof.
Yes, hi. Yashoda, please help me to set you and Cello as co-hosts.
Okay.
So,
I think you have to do
sorry,
though.
where must I go here?
I think those options only come on for the host. So it's probably in settings. I think it's settings. Meeting settings.
Sorry?
Meeting settings.
Sorry, I just need to increase the volume because I cannot hear you properly. It will be in the setting, isn't it? Oh,
Yeah,
sorry.
it says meeting settings.
So must I go to Zoom settings?
No, I think it's in meeting settings. So on your Zoom, the toolbar, the Zoom toolbar.
Okay, but can I do it? Can I do it while now the meeting has started?
I think you can.
Okay.
I'm not sure because I don't get the host settings. You're the only one who gets the host settings.
Really? So,
but it must be under meeting settings.
Okay, but then I'll have to end this meeting and start again. Because I want.
Is it not on your toolbar?
See, underneath is that it just says security, participants chat, share screen, pause or stop recording, and reactions.
And more? There's no more.
Advanced sharing options. It's just about the sharing.
Okay.
Selok, do you know how I can make you and Yashoda hosts? I don't think Selo is listening.
Yeah. Have you done it before, Prof?
No, I haven't done it before, unfortunately. To make multiple hosts for the meeting.
Yeah, because it automatically goes to someone. If you get cut off, someone becomes the host, but I don't know how that's chosen.
Okay, Selo? No, Selo is still dealing with Neo. Luckily, I don't see Prof. Hadley waiting to join yet, so we still have a few minutes.
And you've got his slides. You've loaded his slides.
I've got his slides. His presentation is on my PC. It's also on my flash disk. So, and
okay.
Now Jhandile is sharing screen. I've just prepared like 2 slides, one introductory and one with Prof's photo. So I'm just going to give a very short intro for him.
Yeah.
Selo, is Neo allowing you to talk to me? Selo? It doesn't look like.
Okay, Prof.
Yeah,
Prof
no, I'll stand up when we start. He's just yanking my phone.
Can you help me? I haven't made you or Yashoda host yet. Can you help me?
Because I'm using the phone, so I'm not sure if it shows the complete settings on from my side here.
Don't worry, it may be too late. I think Yashoda or Selo, you just take over. If something happens to my connection,
Sure.
you just take over. Okay.
Sure, Prof.
Okay. Yashoda, you haven't seen Prof. Hadley. I don't see him joining yet. Huh?
No, he's having a bit of trouble getting on. I'm sorting it out now. I'm sending him the link again.
Okay. Okay. So, Jhandile, let me share my screen for a few minutes.
I don't know.
Hi, Neil.
Wait. Hey. Wait. Breathe.
Yeah.
Only nothing. Breathe.
And Yashoda, you can hear me well, huh?
Yes.
Yeah. Okay.
Oh, you're doing okay.
I've got this slide, and then I've got the second slide of his photo.
Okay, just let me know if you see him
Entering the meeting.
Yeah.
Okay.
Because he's trying now.
No, that's fine. I will.
Hi, Prof.
Helga? Hi, Helga. Helga? 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 Hi, Helga. Hi. Yes, I can hear you. I couldn't hear you through the computer. Uh, oh, okay. No, yeah, unfortunately, we didn't manage to do a test meeting, but Prof. Hadley is still not in, so we still have a few minutes. My question was, while the meeting is on, can I make somebody like Yashoda and Selo as co-hosts, or do I have to in the meeting?
Prof?
Yes. Helga, one second, I'm talking to Yashoda. Yes, Yashoda?
I'm speaking to Prof. Hadley on the phone. He's having trouble signing in.
Yes.
Do you see him trying to get in?
No.
Oh, it's getting better, Yashoda.
Yeah.
My account has been locked due to multiple failed login attempts.
Okay, his account has now been locked. Okay.
Helga, I'll talk to you in a second. Okay.
Okay.
Yes, Yashoda?
Uh,
Can you see that I'm trying to join?
no, he can't.
No, he can still log in from the web page. He doesn't have to have a Zoom account to join a meeting.
Yeah, okay. Prof, why don't you do
So if he
this?
just double clicks on the link, it will automatically open Zoom.
Go to the email where the Zoom meeting link is and just click on that link. And then it should just ask you for the passcode.
I will send it to him again now. I'll email it to him once again in a minute.
And that was the email that Lynn sent me.
Yes. He's sending it to you again, just in case.
That's the one where it acknowledged the receipt of the slides. Where is the one? Check this invitation. Invitation 6 minutes ago.
Now I've sent it to him now.
He said he's resent it to you.
Yeah.
Has he? On email?
Yes.
Yeah, it says it is gone.
On email, Prof?
On email.
Hasn't come in yet? No, that's from the manager. Here we are. I'm going to check this.
Shall I send it to him by WhatsApp?
No, no.
I pressed on the join the Zoom meeting.
Yes.
Right.
Right.
And I'll just, it asked me for my email address. I'll just put in my code 671 819. Sign in.
Right. Why is it asking you to sign in?
Your account has been locked.
Okay. Can you use a net email maybe?
Yeah, try that. This is cancel, right? Okay. This is that's embarrassing. I do apologize.
It's okay, Prof. Technical difficulties.
Fine. Invalid email or password. It doesn't say gmail.com. That's the right email address. And the password is 67, whatever it is, 1819. And let me in.
Okay.
Okay, I think I'll just be overcome. Let me go and see if I can use her iPad.
Yes, maybe ask her if she.
She's not here.
Oh, she's not. Okay.
So I'm just going.
Okay, I'm going to call you back, Prof.
It's great convenience of thought for she has taken with her. So the iPad is not here.
Okay.
So I'm stuck, which is a shame because I've got lots of interesting things to say.
I know.
Is there any way I could try firing up my laptop? It'll take a few minutes, but I'll try.
Yeah, but you've been locked out of your Zoom account.
I'll shift all this junk off my desk first to find the laptop. Because I won't have Zoom on this.
Okay.
It shouldn't take me many minutes to download Zoom and find where to download it from. Has your computer started speaking now?
No, we're waiting for you.
That's very clear. Thank you for his patience.
I will. Prof. Hadley, thanks everyone for their patience.
Yeah, that's fine. Thank you. we are also trying to sort out something. So
okay, good.
yeah.
Okay.
I'm trying to sort out making you and Cello co-hosts.
I don't think I've changed anything here. Because I've got to go into general. We don't want to do that. Meetings. We are copy. The ones the meeting starts. Right, where this copy of Windows is not genuine. I know that.
Was a regular week, I'm afraid, because
Yeah, I can see.
You got it?
Yeah, got it, got it.
Okay, okay. You should be joining now.
Okay. Okay.
Yay!
Okay.
Okay. End the call.
It's fine, it's fine.
Okay, great.
Okay. Let's see.
It's okay. If you want to talk to us, unmute yourself.
Okay. Okay, Yashoda, shall we start now?
Yes.
Okay. Okay. Good afternoon, everyone. Thank you for waiting patiently. And soon you will realize that this wait was really worth it. because today Dr. Jula, who is our registrar, is going to talk about rhabdomyosarcoma. He has been mentored by our consultant, Dr. Yashoda Manikchand, and we really have the honor and pleasure of having Professor Larry Hadley as our invited guest. I don't think there is anybody in this audience, in the participants, who doesn't know Professor Hadley. So I really won't say much about his professional achievements and all the research activities. I'll just very briefly mention his strong connection to our Department of Pediatric Surgery in East London. And it goes as far back as the time when the department was in absolute infancy. And I think it was exactly 25 years ago when Professor Hadley was the first consultant from outside East London to visit our department. And I still remember the day when we had presented him cases in the old Ward 25 at Cecilia Makewani Hospital. And since then, Prof. Hadley has always been available for guiding. I remember fondly 2 weeks which I spent with him in Durban in 2004 when I was preparing for my exam. And all our registrars have the honor and privilege of being trained under his tutelage. And we also thank him for giving us Dr. Yashoda Manikchand. And we are not ready to release her at all. Prof, Professor Colin Lazarus, Colin fondly sends his regards and his apologies. Unfortunately, he is still coming back from his leave, so he can't be with us. And our format will be Professor Dr. Jula will present initially. Then I will invite Prof. Hadley to share his thoughts. He has a few slides. And after that, I will invite later Dr. Manikchand and Dr. Machaya to comment. All the other participants, if you have any questions for Dr. Jula or Prof. Hadley or Dr. Manikchand, please just type them into the chat box and we will try and address to them at the end. Okay, so Jandile, I will stop sharing my screen and I will let you share your screen.
All right, Prof, thanks.
Yeah. Okay, you can go ahead. Huh?
All right. Good evening. I'm Dr. Jula, Pediatric Surgery Registrar in East London and Walter Sisulu University. Today, I'm going to be talking about the rhabdomyosarcoma in children. Okay, I'm just going to start off by talking about the definition. So it is just describing what it is. It is a primary malignant in children and adolescents. It is a fast-growing and highly malignant tumor, and it arises from the primitive muscle cells. You need a high index of suspicion, and early diagnosis is a key factor in the prognosis of this disease. So demographics, rhabdomyosarcoma, they form 50% of all soft tissue sarcomas. They account for about 5%, 4.5% of all childhood cancers. And it is the third most common extracranial solid tumor after Wilms tumor and neuroblastomas. Its distribution is bimodal. You have a peak at age between 2 and 6, and you have another peak in late teenagers between the age of 15 and 19. It has a slightly higher preference for male than female at the ratio of 3 is to 2. And it is also more common in Caucasians and non-Caucasian, just to mention. Okay. So histology, it is described as a small round blue cells like most of our pediatric tumors, they are small round blue cells, but what really demonstrate that it's a rhabdomyosarcoma is the immunochemistry, where you want to see if they are desmin and actin and the myogenin. Those are the specific markers that you can pick up on your immunochemical results. Divided into two broad types, embryonal and alveolar. Embryonal being the most common, which has its own subtype, which is a spindle cell subtype, and you have your botryoid subtype as well. Your alveolar is the one that has a poorer prognosis, and it is common more on extremities and the trunk. So this is just a histological picture which basically represents your embryonal histology. This is just showing a dense spindle areas, and you can see also with a loose stroma. How these tumors are actually described, they've got a loose stroma, and you can see them. And then you have your alveolar type, which this one, it shows a dense stroma with a pseudoalveolar space. So this this slide actually under the microscope can show you this and these lines, and it looks like alveolars of the lung, and its name. Okay, so tumor biology, which actually also forms part of prognosis, and it also determines what type of treatment that the patient is going to get. So it's also important in these rhabdomyosarcomas. So for your embryonal type, there is a loss of heterozygosity at 11p and 15 locus. That is where the insulin-like rhabdomyosarcoma. They are frequently tetraploid and translocation on your FKHR gene and from chromosome 13 with either PEX3 on chromosome 2 or PEX7 on chromosome 1. This is associated with a poorer prognosis. And 25% of them, they can be translocation negatives, and those ones, they behave more like embryonal rhabdomyosarcomas. There are a couple of associated conditions with this cancer, with neurofibromatosis. These patients, they have up to 7% chances of getting malignancies. So they are also at a high risk of getting rhabdomyosarcoma. There is other syndromes that are not so common, like your Lee-Fraumeni syndrome, which is an autosomal germline mutation, which basically increases the risk for leukemia, brain tumors, and breast cancer, including the rhabdomyosarcomas. And then you have your Beckwith-Wiedemann syndrome, which we see mostly these kids, they present with omphalocele, they can have microglossia, microsomia, and are in the high risk also of hypoglycemia, but they are also high risk for development of rhabdomyosarcoma. The picture here, what we have is actually a Rubinstein-Tabby syndrome, which these kids, they present with a short stature and they have these broad thumbs on them, on their toes and their fingers. So when you see some of these conditions, you need to think about the risk of rhabdomyosarcomas. Some of the environmental factors that have been mentioned, it's the and cocaine, can be intrauterine exposure to X-ray or previous exposure to alkalizing agents. These are common sites of origin for the tumors. So rhabdomyosarcomas, they've got specific areas that they grow into. They can actually grow anywhere where there is muscles. And these sites of origin, they're actually divided into favorable sites and unfavorable sites, depending on how the tumor in that area does in prognosis. But we're still gonna go into that on next coming slides. So clinical presentation. So this patient, they may present with an expanding mass. It can be painless, or they can have pain, or they can even present with metastatic related symptoms. Can present with bone pain if they've had metastatic on the brain as well, or in the lungs. They can present with the lesion in the chest X-ray, or sometimes it can be picked up hematologically when they've had a bone marrow spread as well. But most of the symptoms, they actually depend on the location of the tumor itself. So in the orbit, this patient, they will present with things like proptosis and paratesticular. It will be a painless scrotal mass. With prostate, you will have your bladder and your bowel difficulties. It could be also bladder outlet obstruction or urinary retention or constipation. Then with your uterus and your cervix, you can have menorrhea or menorrhagia. And in the vagina, you can get a protruding polypoid mass, which looks like a bunch of grapes. And it can somehow be missed for HPV wards. So you just need to watch out if you have young babies that have what you think might be genital warts. It might be something more sinister. In the extremities, they can present with a painless mass, or sometimes it can have, you can have some pain. With your parameningeal, they actually affect mostly your sinuses, so you present mostly with your upper respiratory symptoms. They can also present with your rhinitis, and then that will point you towards that it's more on your sinuses, your parameningeal. So, imaging for investigation. So you can have a plain X-ray for a primary area of concern or a chest X-ray. So this is helpful in determining the presence of calcification and the involvement of bone in primary tissue. And also you can look for metastatic disease in the lungs just from the plain chest X-ray. The role for ultrasound can be used in also as an investigative to look out for the masses, which mostly in the abdomen, it's mostly useful there to identify the mass, but also even for ultrasound guided biopsy. And you can also be able to pick up metastatic disease on the ultrasound. And then you have the CT scan. which basically shows you the extent of the lesion. And then it shows you also if there are metastatic lesions already. And then we also have our MRI. So MRI is a gold standard for soft tissue tumors because you're actually able to see the tissue very well with little radiation as well. So it forms part of the gold standard for being very, you are able to appreciate soft tissue much better than the rest of the of other investigation. And bone scanning is mostly for looking for bone mats. And you can also do a PET scan as well, which can be useful in looking for recurring disease. Okay, so this just shows us an alveolar rhabdomyosarcoma of the calf. You can see on frame A there, it just shows you that there is a soft tissue, looks like soft tissue swelling. You know, you are unable to, you can't really appreciate if there is a mass there or not on just a plain X-ray. But if you do your further imaging, your MRI, you will be able to appreciate that there is actually a mass growing there, as you can see on frame B. And on frame C there, you can see it's the inguinal lymph nodes, they are lighting up there, which shows the extent of the disease. So biopsy is part of our investigation. So what you can use from the tissue that you biopsy, you can use it for histology, for cytogenetic and molecular testing. So you can either use a core needle biopsy. It also depends on where the mass is that you like to biopsy and how accessible it is. Because you can also do excisional biopsy. That's for superficial masses that are small, that are accessible, that you can completely take them out with clear margins. But if you can't, then you will have to do an incisional biopsy. This is mostly for mass that you can't really excise completely, or because of the size of the mass or because of the area where the mass is. So you can do incisional biopsy then. Okay, and so there is IRS group risk. So this is an intergroup rhabdomyosarcoma study group, which basically started in the 60s, which basically looked at how to improve the management of this condition. And if you look at the progress that they have, that has been made in management of this condition, is great, because it started early in 1960, where actually the survival was around, the 5-year survival was around 30%, but now 5-year survival is above 83% with the introduction of the new protocol that come out from this group. So this group, what it does, it stratifies the risk to determine how you're going to manage this patient. So the groups are divided into a low risk, intermediate risk, and high risk. It includes the TNM staging, the site, the clinical grouping, and the histology. So it puts everything into context before they determine the risk. And this is determined by the fact that with the studies that were ongoing, they're able to determine that people who have this TNM staging and this on this site with this histology, they behave a certain way. So they are grouped in the same group for that, because their management is also the same. So this is just a schematic representation to show how the survival based on this group. So your low risk has got up to 85% survival, and your intermediate is about 50%, and your high risk is about 15% as a survival. This also comes from the IRS study. So this is your TNM staging according to site. So your T is for the tumor, which basically your T1 is the tumor confined to the original site, and T2 is where the tumor extends beyond that site. With your nodes, your N0 is there is no nodes involvement, N1 is there is nodal involvement, and NX is when there is unknown involvement of the nodes. And for metastatic disease, M0 is for nomads, and M1 is for metastatic are present. Okay, so now we're looking at the preclinical staging. So this preclinical staging starts from stage 1 to stage 4. So it's based mostly on the site of the tumor. So your stage 1 is your tumor which are on the orbit, head and neck, but that exclude your parameningeal and also your genital urinary system, but it excludes the bladder and prostate. Since the parameningeal bladder and prostate, they actually form part of the non-favorable sites. So they're not part of the stage 1. And in stage 2, it's the bladder and the prostate extremities and the cranial. So this is also, as per stage, it increases with the stage, the prognosis is worse as the stage go up. So with your stage 4, it's basically all the sites, but with metastatic disease. So stage 4 is just metastatic disease. But yeah, okay. So here we have our clinical grouping, which also form part of that stratification of the risk for these tumors. So in your group 1, as basically your group 1 to group 3, those are your localized disease, and group 4 being your distant metastatic disease. So group 1 is basically for your for the tumor that has been completely removed, whereas group 2 is when there is microscopic residual of the tumor, or there is involvement of the nodes, or you have them both, or one of the two. In group 3, you have gross residual tumor on the site. And then group 4 is a distant disease. Okay, so this now here, it's putting into context all those grouping and staging we were looking at: your pre-treatment stage, your clinical group, your site, and your histology. So you have your low to your intermediate and your high. So things to highlight here is that all your stage 4 and clinical stage 4, so your metastatic disease, they all form your high risk. And each of these, the site histology, they're also important in determining the risk group. because if you can see on the histology side, the alveolar histology risk group, it's basically it upgrades the risk regardless of the clinical group or the pre-treatment stage. As long as it's an alveolar histology, it has the worst prognosis compared to embryonal. And then the sites that are also put as favorable and your unfavorable site. Your favorable sites here being your orbit, your genital urinary tract, your biliary tract, and your non-parameningeal for head and neck. So these groups, so these patients then are stratified into these groups, and they are treated according to which group they belong in. Okay, so medical treatment for this patient. Well, the mainstay of this treatment is multimodal. So it's a combination of both surgery, chemotherapy, and radiation. So the treatment itself, it can be prolonged, and it's quite complicated. So you need to have as many people involved with different expertise as well. The surgeon, the oncologist, they must all be involved. And the early diagnosis is imperative in this condition. And then, as we've mentioned, that patients, they are categorized according to the group. And then from then, you decide how to treat them. Just to reiterate that all the patients with the metastatic disease, they are considered high risk, as I've mentioned before. So moving into chemotherapy, also chemotherapy is also based on the risk group of the patient. But the standard treatment is vincristine, ectibicin, and cyclophosphamide. But you can add other agents based on the local protocol, or if it's an atypical type of presentation as well. With the radiotherapy, so for radiotherapy, they are candidates that qualify for radiotherapy. So, and those are your patient in your group 2 with your microscopic residual or your gross residual, and also the patient with the recurrent disease. So with the recurrent disease, it's always you weigh in whether to for surgical resection or radiotherapy. So that's when you decide which one is more feasible. Is the surgery not gonna come with lots of side effects as well, or unwanted outcome as well. So if it's gonna bring more unwanted outcome, you rather have the patient go for radiation instead. Okay, and then surgical care for this patient. So the main part about the surgical management is that it depends on the site of the tumor. And if it's feasible to remove the tumor, then the tumor can be removed without any unacceptable disfigurement or loss of function, then the tumor must be removed completely. So, and with the surgical approach, there's been a move from the vertical surgical approach into a more multimodal form of management. And this helps to prevent disfigurement and loss of function, because these tumors can invade lots of tissues that still need to be used for function as well, that are important for daily life. So preservation of function is important. Complete resection, if it can be achieved, it is also very important. With your primary tumor, you have a couple of options, also depending on the site and the size of the tumor as well. Because you can have your wide local excisions with adequate margins that at least 0.5 centimeters. And also for a primary procedure, you might need to do a relook procedure. So this relook procedure, it can be a relook procedure prior to the start of chemotherapy. After you've done excisional biopsy and it comes back that there's still a tumor left and it can be removed. So that patient can go back and have resurgery just to take the rest of the tumor that is left. And if that's the only tumor present there, that also can be curative. But sometimes the relook also can be for recurrence, or maybe if the initial operation wasn't adequate and they still, you can still operate on this patient. With the recurrent tumor, it's, as I've mentioned before, you have to weigh in whether you're gonna give just radiation and not operate, or you're gonna do both, or just an operation if you can be able to take out the rest of the tumor. With the lymph node sampling, so regional lymph node samples is advocated, but not a radical node dissection. It's not allowed anymore. With the tumors that are in the extremities, they have a high chance of having involvement of lymph nodes. So your femoral lymph nodes and your axillary lymph node, you might need to take them with your, when you have your lymph tumor. But the current recommendation is just for sentinel lymph node biopsy. So, so now I'm just gonna speak about just specific for the site, specific management for the site. So I'm looking at head and neck. So these tumors, they can be managed by chemo and radiation, but they might need surgery. But in most cases, you can be able to manage them with just radiation and chemotherapy. But the parameningeal tumors have got a poorer prognosis. So in your extremities, they constitute about 15 to 20%, which is mostly alveolar. And these ones, they usually affect older children. MRI is the choice of investigation, as we mentioned before. If the lesion is less than 5 centimeters, you can do a complete excision with a clear margin. But if it's in an unfavorable position and it's a large mass, then you can do an incisional biopsy. So with your genitourinary, which constitute about 12% of your rhabdomyosarcoma. So your bladder and prostate, the main thing you want to do there is to salvage the bladder. And it can be a very difficult operation with a lot of structures around there. You have your urethra, your rectum, your bowel, that all can be injured during this procedure. So it's best to do the operation at the best time when you know it can be done with safety. But this forms one of the most difficult rhabdomyosarcoma to manage, because in some patients you might have to take out the whole bladder, and the lifestyle of that patient already is going to change for life. With your vulva and uterus, as I have mentioned, you get mostly your Boetroid type, which they've got a good survival of about 80%. And with them, the involvement of lymph node is really uncommon. And then you get your paratesticular. So these they are in a favorable site, and they're usually your embryonal with spindle sac type, and just a radical occipectomy with a high ligation of a spermatic cord. So this occipectomy is done via an inguinal incision. You try and avoid going through the scrotum, even for a biopsy, because you can cause tumor spillage and seeding of the tumor as well. So these are other sites that are also involved, that form part of the rhabdomyosarcoma. You can have them on your truncle, which is usually high incidence of alveolar. But if you can do a complete excision, then like any other, you have to do a complete excision. Then you have your paraspinal, which on diagnosis you might want to differentiate from Ewing's sarcoma. And then you have your retroperitoneum, you have your biliary and your perineum. And with your biliary, with your biliary rhabdomyosarcoma, they can actually present with obstructive jaundice. They've got with a biliary mass. Then you find out that it's a rhabdomyosarcoma. Metastatic disease, and 15% of the patient, they might present already with metastatic disease at the time of presentation already. And the most common area is your lung, your bone marrow, lymph nodes, and your bones. Recurrent rate is as high as 30%, and it's got quite high mortality rate. It can either be localized or widespread. And the risk factor are actually determined by the size of the margins of resection, the actual tumor histology and biology, which will also determine how bad or how good the patient is going to do. With recurrence, as I've mentioned before, you always have to weigh in your surgery and your radiotherapy. So this is the IRS graph, which shows how the survival your 5-year survival has improved since from the 60s. With what's important here is that initially in the 60s, the approach was more of radical surgery to remove the tumor, and it was high mortality and also probably high disfigurement and function loss. But now you can see that's gone up from just below 30% in the 1960s. By the 90s already, it was going over 70%. So the IRS group has really revolutionized the management of these rhabdomyosarcomas. So with this patient, monitoring is quite important. You want to monitor for recurrence, you want to monitor for long-term effect and the late effect as well. So in general, they say that the patient should be examined every 3 months for the first year, and every 6 months for the second and the third year, and then from that it can be done yearly. Or it can be, or for your late side effects, you can follow them up at 5 years after the end of therapy, and then you can just keep following them up. You need to ask about how they're doing, also psychologically and neurologically evaluation as well, and also how they're doing in school and all those things, because these are some of the effects that this tumor can have in the long run. So I've come down to my summary. It is basically highlighting that the rhabdomyosarcoma is a fairly common malignant tumor of the children. They have excellent response to chemotherapy. The best treatment are achieved with a multi-modal treatment. There isn't just one way to treat them. Surgical treatment can still be curative with when you have gotten local clearance. And there is an improvement in our 5-year survival since the disease was discovered, which is great for us. That's going to be the end of my presentation. And these are my references. Thank you very much.
Prof?
Yeah? Which Prof?
Prof, thank you, Zandile, for the talk. I think it was very thorough. Sorry about the initial technical difficulties. I think you covered it well, but let's let Prof. Hadley take over. Prof, you can start with your comments on his presentation, and then we'll load up your slides.
Okay. Well, my first responsibility is not to comment on his presentation, but to apologize to him and to all of you for the delay caused by my technical ineptitude. I sincerely apologize, but also to thank Professor Chitnis and Dr. Manington for inviting me to be part of this discussion. It's a less frequent privilege these days. But could I have that first slide? Can you go to full screen? Well done. Can we make that full screen, Melinda?
Yeah, 1 second, sir. Oh, sorry.
Mm-hmm.
Yeah. Okay, Prof.
Okay.
Yeah.
Okay. Thanks very much. That'll do beautifully.
And Prof, you can just tell me to change the slide when you want me to.
I'll just say slide, okay? And then you can.
Okay, sure.
Then you can move on.
Okay. Okay.
Yeah, I think we just had a first-class exposition of why rhabdomyosarcoma is confusing. Please. Can we go slide? Let's try it. There we go. As Professor Chitnis said in the introduction, it seems as if I've been around forever. Having first visited East London a quarter of a century ago. But I'd like to introduce you to this chap to put things into context. This is a gentleman whose name is probably even known to our pediatric oncological colleagues. This is Antonio Scarpa, and his fascia is probably the first
eponymous structure that surgical trainees encounter. Could you just press again to just get the slide right? He died at the age of 80 in 1832. And I don't think he was very popular in his department, because as soon as he died, his colleagues cut his head off and put it into a jar of absolute alcohol. They also cut off his thumbs and his penis, but that's a story for another day. But he's still there in his glass jar in a cupboard in the Department of Surgery at the University of Pavia in Italy, near Milan. And so he's been the head in the Department of Surgery now for 180 odd years. So it makes my tenure in Durban look positively brief. We'll have the next slide, please. So why is rhabdomyosarcoma confusing? We've got favorable and unfavorable sites, favorable and unfavorable histology. We've got at least 5 stages, 6 groups, 4 or 5 risk groups. And so you have to put together a matrix for each patient in order to decide how to optimally treat the patient. And the reason for this confusion is historical. Although rhabdomyosarcoma was first described in the mid-19th century, in fact, just a year or two after Scarpa died, it didn't actually attract serious attention until the late 1940s, early 1950s, when it became an object of interest to researchers. Now, in those days, the only research instrument available to the scientists was a light microscope. And so that's the instrument they use. If all you've got is a hammer, then every problem becomes a nail. And when you look down the microscope, you can see the morphology of the cell, you can see the arrangement of the cells within the tissue, you can look at some subcellular bodies, you can see the nucleus, perhaps a nucleoli, and some intracellular structures, and relevant to rhabdomyosarcoma, you can see cross striations. And so everything with a cross striation became a rhabdomyosarcoma. And that was plain and simple. Then they noticed that some patients were doing rather better than other patients with this disease, and so they went back to their microscopes and they identified growth patterns. And they saw that there was an alveolar growth pattern, there was an embryonal growth pattern, a botryoid growth pattern, and there's a very rare sclerotic growth pattern. And they assigned to these prognostic significance. And that would be great. That's where we are. And that's very useful. And it'd be even more useful if we were the least bit interested in morphology. But we're not. We're not interested in what a cell looks like. We're interested in how a cell behaves. And in fact, what we're trying to do is predict how a tumor is going to behave by looking at the cells within that tumor. And of course, the way a cell behaves is governed by the genome within the cell. Of course, there are some epigenetic criteria, and the cell behavior is modified to some extent by the microenvironment in which the cell exists. But by and large, the gene is the important structure. Well, the genes themselves are not very important because genes don't do very much. What they do is simply act as a template for a protein. So it is the gene product that is the thing that influences the tumor behavior. The thesis being that an abnormal gene will lead to an abnormal gene product, and an abnormal gene product can't fulfill its physiological role, and it will have an impact on all downstream functions, all downstream biochemistry within the cells. And it's also important to understand that what we're talking about is a tumor that occurs in the developing myoblast. So somewhere between it being a primitive mesenchymal cell to it becoming a myocyte, somewhere on that journey, a genetic injury occurs which alters the cell's behavior. And that, of course, could happen at the beginning of the developmental process or at the end of the developmental process, and where it happens will influence the outcome. So can I have the next slide? I spoke so long, Professor Chitness has fallen asleep.
Sorry. Okay.
There we go. Now, when I was a lad, rhabdomyosarcoma was the tumor of thirds. A third occur in the head and neck, third occur in the genitourinary tract, and a third occur elsewhere. And the favorable sites were the orbital and non-parameningeal head and neck, paratesticular, and the female urogenital tract. Everything else is unfavorable. It was also a tumor of thirds because you required 3 treatment modalities in order to get survival. You had to have surgery, you had to have chemotherapy, and you had to have radiotherapy. Next one. Right. Today, what the pathologists look for are cross striations and myogenin positivity. All tumors that have those features will be described as rhabdomyosarcoma. 70% of them will be embryonal with loss of heterozygosity at 11p13, as Dr. Jula described. It's a very busy place, the short arm of chromosome 11. That's where the WT1 gene, the Wilms tumor gene, is situated. It's where the insulin-like growth factor that is responsible for Wiedemann-Beckwith syndrome exists as well. The alveolar group will have this fusion protein, the PAX3 or PAX7 and LOX1 fusion, which gives a gene product which affects the biology of the cell. However, in describing these typical findings, it is not likely that you get malignant transformation of a benign cell through a single gene alteration. What you need is a constellation of genes to change the behavior of the cell towards malignancy, to be able to invade, to rapidly divide, etc., and all the features we regard as typical of malignant cells. Right? So you need a constellation. For example, all rhabdomyosarcomas have an abnormality of the gene for p53 on chromosome 17. And p53, as I'm sure you know, is the keeper of the genome. Any genomic damage, p53 will cause a cell to commit suicide. But if the gene on chromosome 17 is abnormal and the p53 protein is abnormal, it won't be able to do that function. And so the cell will be gifted immortality, which is, again, one of the features that we associate with malignant tumors. So it's not a single gene problem. And as we investigate this more and more, we'll come up with probably hundreds of genes that are altered in a rhabdomyosarcoma. And we need to tease out which ones are important and which ones have prognostic significance. But we are where we are, and we're in the middle of a revolution as we move away from light microscopy to genetics as the prognostic determinant. And of course, whenever you're in a transition, things become messy. Can I have the next slide, please? And I find this staging singularly unhelpful because everybody's stage 3, basically. And I just wanted to comment on stage 4 because I think it's important to move away from this Halstedian concept that we have a primary tumor that grows, and when it reaches a certain size, it sends out emissaries to establish colonies elsewhere in the body. I think it's probably wiser to think of pediatric solid tumors as having a multicentric origin. And the primary tumor is dominant simply because the local microenvironment is conducive to growth of that particular genetic type. And it's important to remember this so that we acknowledge that rhabdomyosarcoma, even stage 1 rhabdomyosarcoma, is a systemic disease. And it requires systemic treatment. Next slide, please. And then there's all these. From time to time, it's important to be reminded of one's insignificance. As surgeons, we are not prime movers in the management of rhabdomyosarcomas. As Dr. Jula clearly explained, for many tumors, it doesn't matter whether you operate on them or not. You're going to get survivors. Nobody operates on tumors invading the base of the brain, but the radiotherapists can get there, and the chemotherapists can get there, and there are survivors from the combination therapy in those areas. And it matters very little whether you do a complete resection or whether you have microscopic positive margins. Complete resection is kind of nice, and it satisfies the surgical libido, but it doesn't significantly alter the treatment or the prognosis. Next slide, please. And then we come to risk factors. Everybody is intermediate risk. Well, everybody that we see is intermediate risk. You do occasionally find a low risk, stage 1, easily resectable, group 1, completely resected tumor in a favorable site with embryonal histology, and the overall survival is 85%. But what that means is that still 15% of these patients are dying. So it's not just as straightforward as it would appear. The intermediate risk, which is what we all see, is an unfavorable site, group 3, and stages 2 or 3. And if you've got metastatic embryonal tumor, that's intermediate risk. If you've got alveolar tumor, but even if it's non-metastatic, that is intermediate risk. And your chances of survival are a coin flip. And if you've got a coin flip determining your future, I think it's compelling to provide as much treatment as you can up front. So this includes chemotherapy, surgery, and then radiotherapy. The high-risk patients are basically an experimental group. You can do what you like with them. They are unlikely to survive, and it's worth trying even experimental regimens in this group of patients. And it's important to note also that age is a significant factor, and that if you've got this over the age of 10, your prognosis is considerably poorer than the younger children. Slide, please. Diagnostic tests, Dr. Jula emphasized the need for a biopsy. You can't move without a biopsy. No surgeon on planet Earth is going to remove, do a radical excision of something that might be a rhabdomyosarcoma. So he's going to need information to confirm that it's a rhabdomyosarcoma before he operates. So a biopsy, and in our practice, needle biopsy was overwhelmingly the most common form of initial biopsy. The pathologist will see a small round blue cell tumor with striation and myogenic positivity. We've got to remember to do the bone marrow, as was pointed out. About a third of patients will have positive bone marrows. And imaging, you do whatever you've got. I mean, if what you've got's an MRI, great. If you haven't got an MRI, then do an ultrasound. What we're trying to determine is how operable is the tumor. What would need to be removed to clear the tumor completely? And then we must do the genetic studies. If we don't have the facilities for doing genetic studies at our center, then we should cooperate with another center that does have the facilities, and that we should share the information. The very least that we should be doing is storing our specimens so that when the facilities do become available, we'll be able to retrospectively analyze the genetic lesions. As I say, because not all of the gene abnormalities are going to have prognostic significance, and it's important for us to be able to tease out the ones that do. Next slide, please. So treatment, as is put, excisional biopsy, the very, very occasional small paratesticular tumor can be excised primarily because surgeons believe that there is no benign solid tumor of the testis. So you take it out and then you find out what it was. But needle biopsies are common. And the treatment is neoadjuvant chemotherapy, and neoadjuvant chemotherapy, just like all other childhood solid tumors. Because we're going to have to operate, and the smaller the operation we have to do, the better. And so chemotherapy has a potential to make the surgeon's life easier and happier. And I'm all for happy surgeons. And we used to have the facility to provide brachytherapy in Durban. We used to use it for peripheral rhabdomyosarcomas and for installing seeds and wires into the prostate for the bladder prostate rhabdomyosarcomas. We've lost that facility now, and we are reduced to conformal external beam irradiation. But it's high dose radiotherapy. It's not your 15 gray, it's more likely to be 50, 55, or 60 gray. Next slide, please. And if you don't know, biopsy. Just touch it again, Milan, because this is a rhabdomyosarcoma of the liver. And you don't actually have to have striated muscle in an organ in order to have a rhabdomyosarcoma there, because the myoblasts are distributed throughout the body. If they undergo malignant transformation, then you can have this tumor anywhere. Next slide, please. There are some special situations which Dr. Jula didn't mention. And the first is if you've got a paratesticular tumor in an old boy, in a boy over the age of 10 years, you must do an orchidectomy and you must do a para-aortic lymph node dissection. That's not a cherry picking lymph node, that's a para-aortic lymph node dissection. It improves the survival significantly. Secondly, if we're giving pelvic radiotherapy to girls, then it's important to get the other gonads out of the way. And if we're giving scrotal radiotherapy, get the other gonad out of the way, and we surgically move them up into the lateral wall of the pelvis. Always biopsy nodes at the knee and the elbow. We tend to forget about nodes at the knee and elbow, and they can be positive while the nodes at the root of the limb are still negative. And I would take issue with Dr. Jula's statement that the primary goal in bladder prostate is to save the bladder. And what centers that subscribe to this philosophy end up doing is providing the child with a fibrotic, hemorrhagic, non-expansile bladder with a capacity sometimes of under 10 mils, so that the patient is constantly seeking toilet facilities or is becoming incontinent. They often have pain in the bladder after this. Irradiating the bladder is not nice for the bladder. So organ preservation is, to me, not as important as life preservation. And if we've got residual tumor or recurrent tumor in the bladder, I have absolutely no compunction in taking out the bladder and the prostate and the proximal urethra. And what we would do at that stage is to reimplant the ureters into the sigmoid colon as a ureteral sigmoidostomy for the duration of the oncotherapy. Once the patient has shown himself to be a survivor, then we would take the ureters out of the sigmoid because of the risk of colon cancer, and we put it into the conduit of our choice. Next slide, please. So this is what it looks like. There's a botryoid tumor. You can see the bladder is full of soap bubbles with the bulb of the Foley catheter showing very clearly on the screen. Next slide. And this is what they look like in real life. You can see that there's been an element of obstruction. The bladder is thickened and inflamed, but you can understand why it's called a bunch of grapes. And this is what you see on cystoscopy. And that is probably the commonest way in which biopsies are gained for this particular anatomical site. Next slide. Now, there isn't a surgeon in the world who's going to do a primary anterior compartectomy of the thigh for something like this. That might be a rhabdomyosarcoma, but it might not be. So this child had an incisional biopsy. And then when rhabdomyosarcoma was confirmed, he went back and had definitive surgery after neoadjuvant chemotherapy. Next slide, please. This is what paratesticular rhabdomyosarcoma looks like in Durban. Yeah, the thought of doing primary surgery on this is risible. This child simply had a biopsy and was started on neoadjuvant chemotherapy. We added epiadriamycin to the vincristine, actinomycin, and cyclophosphamide, which was our standard therapy. Next slide, please. And after 4 cycles of chemotherapy, this is what it looked like. And we were able to do a hemiscrotectomy, an orchidectomy, inguinal node biopsies. And he had the para-aortic irradiated as an inverted Y. And we moved his other testes out of the way. Next slide, please. So you don't have to have muscle in the situation in order to have a rhabdomyosarcoma. There's a rhabdomyosarcoma arising in the liver. Next slide. And I particularly wanted to show you this slide because this little girl had a cervical rhabdomyosarcoma, and it was all internal until she coughed, and then the whole thing prolapsed. But what we have seen on a number of occasions is little girls presenting to pediatricians with vaginal bleeding. And the pediatricians intuitively feel the need to exclude child abuse. And they feel that the need to exclude child abuse is so dominant that they don't have to examine the patient. Because if the pediatrician had done even an abdominal examination on this child, he would have felt this tumor mass. We've had children delayed up to 5 months while social workers run around. Social workers are not known for doing things as emergencies, but they run around and make sure that the family environment is safe. If children have vaginal bleeding, examine them. If there's no injury to the external genitalia, do a rectal examination and palpate the mass. Because like all childhood solid tumours in Durban, we treat these as emergencies, and waiting 5 months is simply an unacceptable delay. Thank you. Other than to say, I truly am sorry for holding you up, everybody, and I thank you for your patience. That's my take on rhabdomyosarcoma.
Prof, thank you very much. That was each and every word was actually worth absorbing. I will just hand over to Yashoda. Yashoda, please take over and comment or ask questions to Zwandile, please.
Okay, thanks, Prof. And thank you, Prof. Hadley, for joining us. We really appreciate your presence. Eventually, yes, we got there. Yes, thank you for your invaluable wisdom and experience. You don't find this in textbooks, so I hope all our juniors are appreciating this. Yeah, so I think Zwandile has covered most of it. The only thing was to differentiate between the pre-treatment excision and the second look excision with the rhabdo. So often we get a paratesticular mass, or a scrotal mass rather, and the choice is whether to do a biopsy or to do an excision biopsy, which obviously includes the tunica, and it's a radical orchidectomy. But so with the solid mass, we would do that. But we had a recent patient who had microscopic residual. And the question would be whether to do a pre-treatment re-excision to clear the local tumor bed, because as we know, local spread is a prognostic factor for rhabdos. Or would you treat, which is what we did, we treated with chemotherapy, and then we did a post-treatment CT scan and imaging to assess whether there was any residual or further growth. So there is a question about that, and I don't know if Prof. Hadley has any comments or thoughts on that.
Can I ask you, can I just ask, so that while I'm thinking while you're going to be talking, where was the positive margins? In the scrotum or at the transection of the cord?
In the scrotum. It wasn't very well described on our histology report, but it was in the scrotum. There was no more detail than that.
Okay, thanks.
Yes, so we opted to give chemotherapy and then to re-image. And the other thing was that his imaging showed para-aortic nose, but we opted not to do any biopsies of that at the time of diagnosis. So all we did was that excision biopsy and treated, and then did the following scans, which showed that there wasn't any residual in the scrotum, and that the para-aortic nodes actually had resolved, the lymphadenopathy. So he only had an inguinal clearance, which I don't know if it's, academically sound, but maybe from scrotal spread or something. So that's how we manage that patient in particular. But it just brings into question whether we should be doing pre-treatment re-excision to get negative margins, or or we should, like you're saying, biopsy is needed for chemotherapy and then a proper excision thereafter. But is there a role of re-excision before the chemotherapy is started?
Yeah, I think it very much depends where you are. If you're in the thigh and it's a sort of quadriceps femoris tumor, I've got no problem about doing a primary re-excision. Of course, it's a conundrum in the scrotum, because primary re-excision would mean a hemiscrotectomy. And that's not something that you would choose to do in a child who's going to have chemotherapy. So I think you've actually made the right decisions. I think you've given chemotherapy and you have made all the tumor that is there subradiological. It doesn't mean it's disappeared. It means that it's now beyond the resolution of the tools we have available to look for it. And it would worry me that he's a candidate for a recurrence. And if those nodes were positive, I think I would still, had been positive, I would still irradiate that para-aortic chain.
So would you irradiate him now that it seems to have, it seems to have shrunken with, yes?
Yes.
Okay.
Yes. Yeah. I mean, one of the things about surgery in rhabdomyosarcoma is it gives the pediatric oncologist a better chance of getting a good chemotherapy effect, because we know that chemotherapy is more effective on small tumor volumes. So if you remove and you get microscopic residual in the wound, then I think that doesn't matter, because the chemotherapy will mop it up. But if you've got positive lymph nodes and they shrunk on chemotherapy, I still think that you need to apply radiotherapy to them, because they will recur as sure as eggs are eggs.
Okay, no, that's useful. I will discuss with the oncologists and see if they agree. They tend to use the COG protocols. So
yeah. Well, there's no accounting for taste.
Yeah. So yes, well, I didn't want to get into it, but you did mention that stage 1 you consider a systemic disease anyway, and yet our COG protocols consider surgery upfront as a curative. So
yeah, I mean, I don't think that's the case. I mean, there's still a 15% mortality for stage 1 tumors. And then, I mean, if anything else, I mean, if appendicitis had a 15% mortality, everybody was throwing their arms in the air and crying, "Woe, woe, and thrice woe." No, I think it's still a very significant disease. And I think that we've got to accept that all childhood solid tumors are systemic diseases, and they need systemic treatment. I think to do otherwise is shortchanging your patient.
Yeah, I would agree.
Yeah,
I was talking more about nephroblast, not rhabdos, but just solid tumors in general. I think I agree with you. Stage 1 malignancies are systemic, and chemotherapy is necessary. Yeah, and then I just want to mention for the juniors that I do, for rhabdomyosarcomas, even though we don't have pathologists in public here, we have utilized our private pathologist to come in for frozen sections for these cases specifically. Most tumors we don't stress too much about this, but for rhabdos, and as we are having this discussion, I think they can appreciate that local clearance is very important. So if you can, frozen section would be ideal in these situations.
You're right. Fair enough. Fair comment.
Okay, so I think that's it for me. If anyone else has any questions, comments.
I will invite Selo in a minute. I just want to re-emphasize a few things which, as you correctly said, are not given in the textbook. Only Prof. Hadley can teach such things. Is that for the juniors, just remember the matrix. So it is not linear. It is not only two axes, X and Y. There are actually 4 things to consider when you consider risk stratification for rhabdomyosarcoma. And if everybody heard well, when Prof. Hadley discussed about neoadjuvant chemotherapy, he said those 2 words 3 times. So just remember that neoadjuvant chemotherapy is absolutely critical for these patients. And I also want to agree with Yashoda that these are very useful concepts for all of us to understand, that all malignancies, solid tumors, even stage 1, is a systemic disease. And in fact, that concept of malignancy being metachronous, and because at the host, at the primary site, it just gets better environment, so it becomes larger. I think that's also a very, very useful concept. My only question to Prof. Hadley is, Prof, is it one tumor, or are we not gathering together a spectrum of tumors in rhabdomyosarcoma? Because as you said, they can come anywhere and everywhere, and there are so many variables. So are they not different tumors which we are trying to lump them together under one name?
Yeah, I mean, I think that is the key issue. I mean, I think in any other planet apart from ours, yes, alveolar rhabdomyosarcoma would not be called rhabdomyosarcoma at all. Yes. When you guys are my age, you will not be using the word rhabdomyosarcoma, except if you're giving a historical lecture. You will say that I've got a myoblastic tumor with a fusion protein here and a deletion there and an exon extravaganza over there. Yes, and that gene lesion will define your treatment plan. Yes. You will look at it and you'll say, well, that's a very aggressive gene product there, so we're going to have to give aggressive treatment. Now, this says nothing at all about the treatment modalities, which are also changing now. Yes. Because we're identifying the gene products and we can inhibit their function. So yeah, we're in the middle of a revolution, and it's very exciting. The prognosis for patients can only get better from here on in, because I don't think we should ever be satisfied with an 85% survival rate. Yes, yes. No, that's so nicely said, Prof. Thank you very much. Selo, Dr. Machaya, you still around? Please, you can make a comment.
Yes, I'm here, Prof.
Yes, yes.
Thanks, Mzondile. Very concisive talk, and thanks, Prof. Hadley, for joining us for our weekly fun here. I just wanted to find out something for you, Prof. Hadley, regarding the retroperitoneal rhabdos. What's your thought about debulking? Because as much as you emphasizing neoadjuvant chemo again and again, do you think it plays a role in debulking the tumor, then proceeding with chemotherapy, or we should just go on ahead and do chemotherapy? Obviously, this is once you've biopsied the lesion and know its characteristics. Should we go ahead, just chemotherapy only, or do you suggest debulking?
I would not suggest debulking. To get at the retroperitoneal tumor, to debulk it, you'd certainly contaminate the peritoneal cavity with viable malignant cells. So I don't think I would go that route. I think what I would do is I would give neoadjuvant chemotherapy up to, say, 4 cycles of Vaccasia, and then I would re-image and see whether that hadn't now become completely resectable, rather than going in and trying to remove half of it. There's a difference, just so that everybody's aware, between debulking and leaving a microscopic residual. Debulking is in fact leaving you with gross residual disease. And the question is there any advantage of having gross residual disease rather than slightly grosser residual disease. And I would say, no, I would go ahead and give the neoadjuvant chemotherapy and monitor the response radiologically. And you can usually do this with ultrasound on the retroperitoneum.
Okay, okay. No, that, yeah, that clever, because I was like getting slightly confused in a sense, because when you were looking at the IRS specifically for stage 4 back in the days, in the late 80s, early 90s, they had shown some event-free survival or increased survival over a 5-year period after you've debulked a tumor, specifically the embryonal type versus the ones without debulking. So if obviously this does not bear any benefit to the patient, then I think this kind of that notion was most likely then more old school way of doing things than the modern way.
I think so. Up until the end of IRS 2 and the beginning of IRS 3, upfront surgery was the treatment of choice. So if you had, for example, a bladder prostate rhabdo, the first thing that would happen to you is you'd have your bladder and prostate removed. And obviously there were some survivors, but there was an awful lot of morbidity and an awful lot of mortality attached with that approach. I think it's become very well established over the last certainly 25 years that neoadjuvant chemotherapy sometimes makes surgery possible, and it always makes surgery easier and safer. And part of our responsibility is also, of course, to reduce surgical morbidity and surgical mortality. And by reducing the magnitude of an operation that needs to be done, we assist in that ambition as well. So from my perspective, I can't think of any childhood solid tumor, possibly 1 or 2 skin lesions, that don't benefit from the neoadjuvant chemotherapy. Added to which, you can monitor your tumor response. If you take it out, you've no idea whether your chemotherapy is working.
True.
So, yeah.
Okay, thanks, Prof.
Okay.
Thank you, Prof. I think those of the participants who haven't read your articles which you published about 35 years ago, they need to just revisit those articles, and all these things which Prof is advising now about giving neoadjuvant chemotherapy to make tumors shrink and to reduce the extent of the operation and the morbidity of the operation, and obviously all the chances of complications during operation much less likely, in addition to making surgery easier. So that is very good. Prof, just I also liked your advice to us surgeons that in exceptional circumstances, there are still indications for radical operation like total cystectomy in a child with bladder rhabdomyosarcoma with a very small capacity bladder. I think it is something just additional information for us surgeons.
Yeah, it's very easy to end up putting in a lot of effort to salvage an organ that is no use to the patient.
Yeah. No, absolutely. And Prof, as you correctly mentioned, about 25 years ago, just before we started, radical surgery, cystectomy was the procedure of choice because urologists used to do those operations in East London, and some of those patients did quite well. So in fact, when Colin and I started, we introduced the concept of joint pediatric oncology clinic round, and then obviously the chemotherapy started, and the new era of the current era of cancer treatment started in East London.
Well, I'm pleased to hear it.
Yes. I see there are 2 other specialists from other centers. One is Professor Cipularo Neveleni. Are you still around? You want to make any comment?
I think he left.
Has he left? Okay. And is Dr. Mangre around? Dr. Hansi Mangre? Hansi, you want to make any comment?
Milind.
Yes, Hansi.
Thanks.
Yeah.
Thanks to the team and Prof. Hadley for giving us this.
Hi, Hansi. How are you, man?
Hi, Prof. Firstly, I just want to congratulate Milind on extending this invite to all the other trainees and pediatric surgeons in South Africa, because I think it's a wonderful effort to sort of share our knowledge on a local sort of platform and share our experiences and learn from that. So I just have two comments. One is, regarding that paratesticular rhabdo, and just for the trainees to note that you're dealing with two lymphatic fields. So you're dealing with the sort of para-aortic lymphatic fields that's draining from the testicle, and then you're dealing with the inguinal lymphatic field that's draining your scrotum. So in making your assessment and staging, depending on the size of the nodes involved, you need to biopsy both sides. And that's going to impact on it, your sort of staging and then your treatment thereafter. And then the other thing is that, we often sort of write off what can I say, warts in kids. And I know not so long ago, the guys in Durban did get caught off guard by having treated sort of like recurrent warts, and which eventually was biopsied and presented was found to be a rhabdomyosarcoma. So just so that the junior guys don't get caught off guard with treating these as warts and then later on to find a metastatic tumor. But thanks, Milind, and thank Prof. Hadley for your insightful lectures.
Thank you, Hansi. Those are very practical comments. Yashoda, do you have any concluding remarks?
No, Prof. I think we've covered everything. Just to reiterate again to all our juniors that early diagnosis, high index of suspicion is key, and to all our district level hospital doctors that are here, that are joining us, that solid tumors in children grow fast and they need to be addressed quickly, and prompt investigation and management is life-saving. So the child with that leg pain and you do an x-ray and it looks like swelling, you must have a high index of suspicion. So yeah, that's my last comment. And then to Prof. Hadley, next time I'm in Durban, I owe you a beer.
just one.
So
I look forward to it.
Yes, Prof. Hadley, thank you very much. Yeah, we ultimately, as a team effort, we managed to overcome the problems. And I must tell you that you had great help from two women. One is Yashoda and second is your wife. Without that, you couldn't have participated.
Yeah, I'm afraid that you're absolutely right. Without the women tonight, life would have been very difficult indeed.
So, Prof, thank you very much. It was really nice having you on virtual platform, and we will try our best to get you physically in East London as soon as the travel restrictions are lifted. And we look forward to welcoming you once again, at least in 2021 in East London.
I look forward to it, Milind. Thanks very much for inviting me, and I think you've got a great program going. Well done. Okay, thank you, Prof. Thank you all for participating and waiting patiently. We appreciate your presence, and we will see most of you next week. Have a good night, Prof. Bye. Bye-bye.